Thank you, Dave. Thank you, everybody, for having me back. It's a real honor, and I learn from these, so thank you very much for letting me sit in and participate in the discussion as well. And thank you all for being a part of the ECHO community and family. And it's all of you who make this such a robust learning and support network, so thank you. And these are some of the objectives. I think for those of you who work with a lot of people living with HIV, some of this may be a review for you. If you don't, hopefully I can give you some pearls to help when counseling or when helping manage somebody with HIV. So we'll talk a little bit about where we are in HIV treatment right now in 2019, and then some key points with HIV-TB co-infection, with the biggest two questions that come up in my experience being, when would you start ART? What's the timing of TB treatment and ART? And then how do we manage drug-drug interactions, because they can be challenging sometimes. First, where are we with HIV treatment right now in 2019? Things have shifted a lot in terms of who we offer ART to, and really the take-home point is right now in 2019 we offer ART to everyone with HIV regardless of their CD4 count. The lower the CD4 count, the more urgent the ART is, but anyone with HIV regardless of CD4 count should be offered ART. And there's also a really big shift towards offering it as early as possible, even the day of their diagnosis or their first clinic visit, if that's logistically feasible. The reasons for that, number one, is data for improving health for that individual person. And then number two, this phrase, which we use a lot these days, and which I really would encourage you to become familiar with, U equals U, or undetectable equals untransmittable. There is very strong data nowadays that somebody with HIV taking ART, maintaining a suppressed viral load, does not transmit HIV to other people. And that has led to this big campaign called U equals U. If you Google that, there's our websites that come from a group in Boston called the Prevention Access Campaign. They're the ones who have developed this and spread it around the world. And it has done dramatic things towards reducing the stigma and the fear and the shame that people with HIV feel. So key point, everyone with HIV should be offered ART regardless of CD4. It improves their health, and it dramatically reduces the risk of transmitting to others. And people with HIV with a suppressed viral load do not transmit it to other people. Now we'll talk about options for ART and how to manage interactions. The one pearl I want to mention here is that if somebody is not on ART, they certainly should be geared up to start it. If they're on ART and now you're trying to manage side effects, switching ART does require various considerations, and often should be done with a review of their past regimens, their resistance, past intolerabilities. So if you're in a situation where you're switching ART to avoid drug-drug interactions, please feel free to reach out to us here, and we're always welcome to help. And then IRIS is something we often talk about, and I'll use that term, so I just want to highlight here. IRIS, or immune reconstitution inflammatory syndrome, is a situation in which somebody with an opportunistic infection like tuberculosis is on treatment, they're doing better, they're improving, and then you start them on ART or HIV therapy, their immune system ramps up, and all of a sudden they get worse because of that robust inflammatory response. And you're giving them their immune system back, and you want that, but that surge in their immune system, that surge in their inflammatory response, can make them clinically worsen. And that's called paradoxical IRIS, or we talk about unmasking IRIS, where somebody had an OI you didn't know about, weren't treating, you start them on ART, and then they get worse and you find their OI. So we'll come back to that term as it relates to TB. In terms of timing of treating HIV and treating TB, I think in general, the way I think about it is if somebody has latent TB, usually I'll start ART first, make sure they're tolerating it, think about the drug-drug interactions, and then start the treatment for latent TB. Once I make sure they're tolerating their ART, that tends to be the more straightforward situation. If somebody has active TB, generally we want to start TB treatment first, then start HIV meds, then start ART. Again, we want to make sure they're tolerating their TB treatment, want to make sure the TB is under treatment to reduce that risk of virus once we start ART, and we'll talk in more detail about the timing. So when I started training and studying in this field, really the paradigm was complete their TB treatment, or complete at least a couple months of TB treatment, then start ART. And again, that has shifted towards starting earlier and earlier. This is really just for your reference, but these are the 3 studies, primarily in pulmonary TB, which randomized participants to either start ART relatively early, generally about 2 to 3 weeks versus waiting until after the first 2 months of TB treatment. You can see here where these studies were done. SAPIT was all pulmonary TB. Strident and Camellia were primarily pulmonary TB. So we're really mostly talking about pulmonary TB here. And then the key point here, the real punchline here is that for individuals with HIV and a CD4 count below 50, starting ART within 2 weeks led to dramatic benefits in terms of reductions of mortality and AIDS complications. So it is very clear that if somebody has HIV with a low CD4 count, for example, less than 50, starting ART early, defined as less than 2 weeks, has long-term benefits. Now, it does raise the risk of IRIS, again, that clinical worsening once you start the ART, but that generally is manageable with anti-inflammatories like corticosteroids and generally is not treatment limiting and does not increase the risk of mortality. So even though there's a higher risk of IRIS with starting ART early, there clearly is benefit, especially for those individuals with HIV and a low CD4 count. TB meningitis is a little bit of an unknown right now in terms of the best timing for ART. The jury's out. This was the one study done in Vietnam of 253 individuals with HIV and TB meningitis, all got ripe in a 6 to 8 week tapering course of dexamethasone, and then they were randomized to ART either immediately, starting in about a week, or after the first 2-month intensive phase of TB treatment. And there really was no difference in mortality in the survival curves, which you can see here. So there was no clear long-term survival mortality benefit to early ART, and they did report increased rates of grade 4 adverse events in the immediate ART group. So there was no clear benefit. However, there were also, I think, was no really clear harm to early ART in this group. And there are some difficulties extrapolating this. This is an old regimen we would never use here. We would never prescribe AZT here. We've really gotten away from efavirenz. It was unclear how regularly these individuals could be monitored. And if you look at the survival curves here, the mortality rate was really high. This is less than 50% survival at 12 months. So this was a study with a very ill population with a very high mortality. And so I think here in this country, the jury is out in terms of the optimal timing for ART in the setting of TB meningitis. So here's a summary of the 3 major guidelines groups in this country and what they recommend in terms of timing of timing of ART for somebody with HIV and tuberculosis. So with a CD4 count less than 50, clearly all the guidelines agree, start ART within 2 weeks. If CD4 is above 50, there's a little more wiggle room, and the guidelines say, yeah, you should probably start by 8 to 12 weeks, within 2 to 4 weeks if there's evidence of severe disease, or within 8 to 12 weeks if no severe disease, or by 8 to 12 weeks. So a little more wiggle room there. But usually once somebody's tolerating ART, we would still go ahead and start somewhere around that 2-week mark. And then TB meningitis, you can read this. It's very vague. No one knows the best timing. I think the one instance in which we really worry about early ART is cryptococcal meningitis, because IRIS can be so severe and that inflammation inside the cranium can raise mortality and can be life-threatening. And so with cryptococcal meningitis, we often wait to start ART, especially if somebody has severe disease. TB meningitis, I again think the jury's out, and we'll often start once somebody is tolerating their ART and then just do really, really close clinical monitoring. Let's talk about ART options right now in 2019 as they stand. And if you don't do a lot of HIV clinical care, hopefully this will be helpful. If you do a lot, hopefully this will be a good review, and please feel free to jump in with questions or comments at the end. So this is the major guidelines group in the US. You can see where these come from at the bottom. And these are really the quote unquote first line regimens, or the guidelines say recommended regimens for most people with HIV. You can see here that there are several options that are just 1 pill a day. This option here, which combines a potent integrase inhibitor and 2 NRTIs, is probably our most common first prescription for somebody with their first regimen in our HIV clinic. We will then in just a minute talk about some of the interactions which make it such that this was not your best choice for somebody with HIV-TB co-infection, but this really is our most common prescription in HIV clinic these days, probably followed by this second option here, integrase inhibitor, and then 2 NRTIs as 2 separate pills. But you can see here there are a lot of first-line options that are 1 pill a day or 2 pills a day. Our go-tos, again, are this one, followed by this second one. However, the drug-drug interactions for somebody with HIV and TB do definitely affect that choice. So again, this is mostly here for your reference. These are the second line options. I'm not going to go through all of these, but again, you have them for reference. I just want to make a point here that ATRIPLA, which we used to use so much, efavirenz with 2 NRTIs, we really do not start people on anymore. But for somebody with HIV and TB co-infection, that there may be reasons why you would reach for that. So again, in the setting of co-infection, it really affects our choice of antiretroviral therapy. And then just to highlight, there are a couple other 2-pill combos that are approved that we don't reach for very often. But what I wanted to note is within the next 6 to 12 months, we may see approval of the first long-acting injectable HIV medications. There are 2 long-acting injectables that have completed phase 3, and a new drug application has been submitted to the FDA. So this is a long-acting intramuscular integrase inhibitor and a long-acting intramuscular NNRTI, which are being studied as 2-drug maintenance therapy for somebody who's already achieved a suppressed viral load. And they're being studied for HIV treatment with every 1 to 2 month dosing, and this one is being studied for HIV pre-exposure prophylaxis as well, every 2 to 3 month dosing. So that may be a major shift in HIV treatment here within the next year, is some people may qualify for long-acting injectable therapy. So I just wanted to note that, but let me switch to drug-drug interactions because this is where things can get messy. I'm going to make a couple key points. I'm going to show you a table, which again is for your reference, and then happy to take any questions or comments. So in general, with HIV meds, there's no issue with the TB drugs and an NRTI backbone, except for one, and I really want to highlight this because it is not intuitive at all. The NRTI TAF, or tenofovir alafenamide, we reach for so much in HIV treatment. That's really our go-to for most individuals for HIV treatment. It is not recommended per the guidelines to be combined with the rifamycins until we get more data. So we're often reaching for TAF as part of HIV treatment, whether somebody's starting anew or whether they're on a salvage regimen. TAF and rifamycins right now, the recommendations are to avoid. I'll come back and say what and explain more why I'm saying right now and why that may change. With the anchor drugs or the non-NRTIs, usually when choosing HIV therapy for somebody with TB, we'll avoid the protease inhibitors, avoid the pharmacokinetic boosters, the cobicistat, the ritonavir. Those are the ones with the most drug-drug interactions. Those are the ones that interact with the most with all sorts of stuff, statins, for example. The rifamycins do lower integrase inhibitor levels. Often that can be overcome by increasing the integrase inhibitor dose, especially with integrase inhibitors like dolutegravir and raltegravir, which I'll show you. So those often end up being a good choice. And then efavirenz, which we really have gotten away from in HIV clinic because of side effects, particularly side effects on mental health and increased rates of suicidality. It is one of the few HIV anchor drugs that is okay with the rifamycin. So this is one rare instance where with HIV therapy, we may still be reaching for an efavirenz anchored regimen like ATRIPLA. So this, again, is not for memorization. We're not going to go through all of it, but as reference, just to make a couple key points. And really, I think the take home here is if you are helping manage somebody with HIV TB co-infection or HIV and latent TB and you're considering drug-drug interactions, please feel free to reach out to us. Please reach out to our pharmacists. They are always willing to help. Please use one of the drug-drug interaction checkers online or one of the tools. And just always consider the drug-drug interactions because there are reasonable options. So again, the NRTI TAF or tenofovir alafenamide right now per the guidelines is not recommended with any of the rifamycins. The reason I put a question mark here and I'm saying right now is there was one study presented at a recent conference that showed that even though blood levels of TAF decrease on the rifamycins, the intracellular levels seem to be fine and above IC90s and as good as with TDF, the older tenofovir. So it may be okay, but guidelines have not incorporated that yet. And thus far, we are trying to avoid TAF with rifamycins if we have other reasonable options. All of the other modern NRTIs are okay. Abacavir, emtricitabine, lamivudine. If you see somebody on an older NRTI, the AZT, D4T, anything like that, please contact us and we're happy to help you figure out a reasonable strategy to get that person off those older toxic meds. With the integrase inhibitors, I think this is a really key point. So while we love bictegravir for first regimens, it really is not an option with any of the rifamycins because it is only available as that combo tablet with tafin and procydabine. You cannot get it on its own, so you can't increase the dose to overcome the lower levels by the rifamycin. So bictegravir really is not an option. Boosted elvitegravir, which is in single tablet combinations like Stribild and Genvoya, really is not an option because of the cobicistat interactions. So what end up being our best strategies are raltegravir or dolutegravir. With rifampin, we double the dose of those meds. And so here I've given you an asterisk where we've increased the dose of those meds. With rifabutin, these are okay. With weekly rifapentine, these are raltegravir and dolutegravir are probably both okay. The question mark here was there was an early study done by the INH of dolutegravir combined with weekly INH rifapentine, and they stopped it early because people had flu-like illness and an increase in their AST, ALT, and elevated cytokines. But it was only 4 people. They stopped when 2 out of 4 people developed those symptoms. So it was so small. And then more recently, a study of 60 people was presented at one of our big HIV conferences where it looked fine. So I think that dolutegravir combined with weekly rifapentine is probably okay. We really don't have data on daily rifapentine for either of these. And then, as I mentioned, efavirenz, the NRTI that we as HIV treaters kind of cringe about these days and try to avoid, is okay. So that is one instance in which we may reach for that. The other NRTIs are out with rifampin and rifapentine, and the boosted PIs we really try to avoid because they're just messy in terms of drug interactions. So again, that was not meant to be something you would memorize, simply a couple key points. And I think my biggest take-home message is just remember, if you're seeing somebody with HIV TB or HIV and latent TB, consider drug-drug interactions. Generally, there are ways to manage and get around those, but sometimes you do have to be creative, and we are always happy to help. I think I will close with that. Thank the team here again for having me, and I hope there was something useful there for everybody, and I'm happy to answer questions or hear any comments.